Good morning, good afternoon, good night, wherever you are, and welcome to this TechNet webinar, the third one in a series of 5 webinars on data use research led by JSI and Sonder Design Collective. The topic today is policy versus practice, two modes that reflect decision-making in the Kenyan health system. We're happy to welcome back Isaac Mugoya, Senior Technical Officer at JSI, Emilia Klimiuk, Project Lead at Sonder Design Collective, Sarah Hassanen, Kenya Lead at Sonder Design Collective, and Wendy Prosser, Senior Technical Officer at JSI. During the presentation, you can submit your questions in the Q&A box at the bottom right of the window, and the panelists will answer them at the end of the presentation. This webinar is recorded and will be made available on the TechNet website in the webinars area. Wendy, the floor is yours.
Thanks, Alex. This is actually Emilia with Sonder. So thank you again for all the participants who are joining us. For the first time, we're also repeat participants. And thank you again, Alex, as well as TechNet for hosting this webinar series. So today we are really excited to talk to you about two different modes, as we're calling them, for decision-making that we have uncovered during our research in Kenya. So just very briefly, as an overview of the context in which we've gathered these insights, this is a project called Vaccine Data Insights, and it is, as Alex was saying, a collaboration between Sonder Collective and John Snow. And we're taking a human-centered design approach in order to kind of uncover challenges and the root causes of those challenges for reasons why maybe data is not being used for decision making, or if any kind of issues along the way in the collection and use of data. The study covers 3 countries, Kenya, DRC, as well as Mozambique. So far, the project that we've completed research in Kenya, and our research in DRC and Mozambique is on pause. So the insights we'll be sharing with you today are based on our research that we've done in Kenya earlier this year. And just for context, we went to 3 different counties, 13 facilities total, and 84 participants. So in terms of what we'll be talking to today, as I've already mentioned, is these 2 different ways that decisions are being made. These, we're calling them modes or models, and kind of their implications for how these decisions actually get executed, and kind of the processes around the immunization program in Kenya specifically. So the 2 different modes we're talking about here, one is policy. This is the kind of the official mandated ways that things are supposed to be done. So these are the formal data-driven planning processes, which unfortunately rarely reflect the reality on the ground. And on the flip side, what you see is kind of the solution, or the hacks that have been created around to bypass the policy, or to deal with the consequences of some of this lack of reality. And that's what happens in practice, which is oftentimes quick judgment calls that are happening perhaps as a single individual. So they're grounded in a local context, but they very rarely are based on any of the official data. So diving a little deeper into the policy side of things, the formal data-driven planning. So these are things like target setting meetings, forecasting, and budget setting at all levels of the system. So in terms of thinking about the strengths of these processes, they're very strategic and proactive, and they do involve a lot of data reviews and incorporate all of the available data in the system. And they do a very good job of achieving team consensus and kind of awareness throughout the system of the decisions that are being made, because they are formal and strategic. On the flip side, there are many challenges with these processes. So because they are group activities, they require a lot of effort and funds, which are not always available to organize these meetings of people from multiple levels of the system coming together to make decisions. And as a result, a lot of times what we've seen in the research we've done is that these activities don't happen on time. So you might go to a facility and they're still using forecasting or targets from the year before because the county or sub-county had not had the budget to bring people together and have this formal planning process. Another kind of challenge around this process is that they do oftentimes fail to reflect the reality on the ground because they are using data that is largely perceived as inaccurate. And as a result, people might not fully believe or respect the planning that's coming out of the process. And then finally, another very significant challenge is that even after all of these planning activities have been achieved and the data has been used to make these plans, the resources that were planned for don't necessarily materialize in full or on time. So for example, if we're thinking about a budget setting meeting, the budget then does not come in full or comes very late. So it feels like the activities are in vain. And we'll jump into some more specific examples of this in a second, but I'll go over the second mode, which is the practice mode, these quick judgment calls, and kind of the strengths and weaknesses of this one as well. So for the quick judgment calls, these are things like, as a manager, reshuffling stock across the facilities to avoid stockouts, which is happening it's a very responsive process. Figuring out what to do when a fridge at the sub-county breaks and all of a sudden supplies have to be moved somewhere else, or figuring out how to spend those limited funds that are coming and maybe coming late. So the strengths of this process is that it's very quick and efficiently addresses the issues at hand. So it's very efficient and reactive. And it does by necessity reflect the reality on the ground because it is a very bottom-up process, and it forces innovations. So it forces people to think a little bit differently, and sometimes it kind of inspires people to come up with creative ideas for how to solve problems that might not necessarily survive through that more official strategic planning process. On the flip side, in terms of challenges, it is usually a very rushed activity that might be happening with just one person struggling with an emergency. It's not strategic, and it is more reactive. It's oftentimes a knee-jerk reaction, which also does not rely on data. So it usually relies much more on intuition and kind of experience of the one individual, as opposed to a more careful review of the data that's available. And lastly, it doesn't contribute to the overall system. And so now I will hand it over to Isaac from Kenya to give us some more specific examples of how these two different modes play out in practice across the different levels of the system, which is the national, subnational, and the facility level.
Yes, thanks, Emilia. The clash between policy and practice meaning what people are able to do because of the need of the moment, was actually evident at all levels of the country. We looked at the three levels, that is the national level, and the sub-county levels, and the facility level. The sub-county in this case are the equivalent of districts in many countries. We're starting at the national level. Most of the things that the national level has to be informed by data. Planning for vaccine procurement, distribution, and also budgeting has to be informed by the data. Now, because of a devolved system of government, sometimes now the national level doesn't have a very direct access to data at the facility level. There are several layers that has to go through, but work has to be done. So you find that the people at the national level have to plan, but they have to have data. What they do, they have to spend a lot of time trying to follow up that data through a chain that may not be very effective. And because of constraints in terms of time, we found that planning for stocks, ordering, and also is based on estimates from the previous years. not necessarily a bad way of doing things, but also not very accurate. Because of this inaccuracy at the national level, this is translated when you get stocks that have been budgeted using inaccurate data, or targeting that is done using inaccurate data, or planning budgeting that was done using inaccurate data. This often stays to the other levels of the systems, and these effects have a ripple effect across the system. So next. Now, at the subnational level, both at the county and the sub-county level, the main thing that we found they are struggling with was the issue of target setting, mainly, plus vaccine forecasting. At the subnational level, we realize that the clash between policy and policy is where it becomes very evident. For example, target setting that has to be that has to happen every year between the county, sub-county, and facility staff to discuss the targets for the year for each facility. It's supposed to happen every year, but because of time, it is time consuming. Sometimes there is no money to hold those meetings. It requires people to leave their facility, and there's a lot of competing activities that are happening at those levels. They have to rely on data that may not, the meetings may not often happen. And the planning has again to rely on data which has to be cleaned and negotiated along the levels. And this affects the quality of the data for planning. And because a lot of time we spend negotiating, and takes prolongs the agreeing of the target facility, which are used to assess performance of the facility. The other thing we realize that this affects the number of stocks that we get, because if you depend on data that is inaccurate, that you're going to get a stock that is not accurate, that's not adequate. And this has often been a point of contention between the participants at different levels, because the facilities may feel that they are not getting the stock they need, and it is because what was planned for at the sub-county level was not adequate for the facilities. And this would force facility to act in a certain way that may not necessarily be according to policy. The next thing we found was the population numbers are also not very correct. Because the people are used to using numbers that are not correct, they by default assume that every other data generated using that target is going to be inaccurate. And one of the complaints that we had a lot is that counties and some facilities saying they have targets that are reachable. They have done their best, but they can't reach these people. And because they are assessed against a target that for them is inaccurate, they feel frustrated. And this fits along the level, all the levels of the system. So at the facility level, next. At the facility level, this is where the clash is the most acute, because this is where the nurse is almost a one-person show. The numbers that are used to order the stocks are the target numbers that are inaccurate. And these numbers are respected at the higher levels. However, the facilities know that my numbers are not the same as the number from the sub-county. But she may have less children to target compared to what she's asked to target. That is not necessarily a bad problem in terms of stock management, but it is bad in terms of performance monitoring, because they are assessed against number and they feel that they have done their best, but yet they are labeled as poor performing facilities within the county or within the county, and that motivates them. The other side of that is that they may have targets that are higher than the stocks that they are given. And this forces them to try as much as possible to ensure that they have enough stock for the children. So you find that vaccines like measles containing vaccines, they schedule them, which is again is a policy. The policy says that you vaccinate between Monday and Friday between 8 and 5, and the maternities that the facility with the maternities can vaccinate on the weekend with BCG and OPV. However, because the facilities get less than adequate, they are forced to schedule these vaccines. And this has an impact on the coverage, because they cannot achieve coverage if they have to schedule certain days. And the final thing is that we discover that when it comes to budgets, most of the activities, they plan a lot, they spend a lot of time and manpower planning and budgeting. However, these budgets are not respected in the sense that they get inadequate funds, the plans are not honored, they are given a block of resources and asked to use those resources that are available. So what happens is that they see budgeting and planning process like an exercise in futility. And therefore they are not so enthusiastic. They would rather continue doing what they do best because that they are learned to using it. This is why you find that now the nurse is torn between, do I respect the policy and do what the policy requires me to do, or do I make a decision that makes sense to me? And quite often they will gravitate towards the practical things that are able to solve their problem at that moment. So that is the main thing that we found. So the clash is on target, on stock, and budget. And I think that is the main things we had on at the facility level. Next.
Thanks, Isaac. This is Wendy, and essentially what we're saying is that health workers create these workarounds, these ad hoc approaches to address that current situation, right? There's specific policies and standards that they have to follow, but to make their work practical, they create these workarounds, these ad hoc ways, just to be more responsive and agile. It creates inefficiencies for sure, because you're duplicating efforts. They spend a lot of time planning their annual plan, but then reality hits, and you just have to make quick decisions based on what funds are available or what emergency is happening currently, or shuffling the stock around. And these workarounds still respect the standard policies, but they adapt to fit in the specific context. And where this comes into play, as Isaac mentioned, is the performance aspect. So they have these workarounds that make their work easy and make it more responsive, but those don't fit into the standard performance metrics that their supervisors are looking at. So there are a lot of innovative things being created in an ad hoc way, right? Like there's one example of a notebook that a nurse was using to track BCG in the maternities because she doesn't want to take all the registry books from immunization into maternity to track BCG. It's a quick and easy example. And this was they called it an institutional thing that was specific to that facility. How can that type of innovative new idea be taken to other facilities or be adapted in a different way? It's not recognized by a standard policy and practices policy from the national level, but it's a best practice that could be adapted in other places to help other healthcare workers with their daily routines. So this is almost kind of a call to action. There are new ideas out there that are being developed by health workers on the front lines that are having to deal with just daily practices and best practices and creating systems that work for them. And how can those be adapted into other situations to become more responsive decision-making that depend more on intuition and agility than on those very standard protocols? Because at this point, we need this innovation, we need agility to react to the situation in that immediate context that may not be directed by official policies that are coming from the national level. So we want to open it up for questions now. I will pass it to Sarah for questions. And then please, as Alex mentioned, please add your questions into the Q&A box and we will address those along the way.
Thank you, Wendy, and Emilia and Isaac. It's Sarah here. I'm just asked you again in the side chat box as well. If you have any questions, please send them through either through the Q&A or on the side there, and we can get to answering them. But we have had one come through. And the question is, what are some of the reasons why the facilities receive less than the amount of stock they ordered?
I can jump in on that, but Isaac, it would be great to have your opinions as well. What we saw during the research, and we actually see in many countries as well, is that the sub-county doesn't have enough stock for everyone for the monthly quantities that are planned. So it's they send what they can. Also, we've seen that sometimes the sub-county level doesn't necessarily trust the numbers that they're getting and the reports they're getting from the facility level. So they just may change based on what their forecasting says is needed rather than what the facility forecast says is needed. Isaac, do you have some additional insight?
Yeah, thank you, Wendy. In addition to what Wendy has said, what we have seen that there is this concept of wastage rate. And that contributes a lot to facilities not getting adequate stocks. Because when we ask facilities to forecast their need based on their wastage rate, when they do that, sometimes that is, of course, that's because of that any wastage rate, they would need higher number of doses than the number of children. And the people managing vaccines at the depot may not necessarily have that understanding that these numbers is high because this facility, because of the nature of the facility, it is a small number of children, then their wastage rate is very high. And the second thing is that wastage rate is not, people do not understand the value of wastage rate. The wastage rate is not that it has to be applied uniformly across facilities, but it has to be specific to the facility. So this notion that the facilities are doing a bad thing by having high wastage rate may not necessarily be they are doing a bad thing is one of the things that contributes to facilities getting less stocks. I'll give you an example. A BCG vial contains 20 doses, and the policy is that you can open a dose for a child who comes for BCG. But what happens when a nurse follows that policy, and then she says, I have 10 children per month, but I also need 10 vials of BCG because she sees one child per day. The county tells the depot tells them, no, your wastage rate is too high because you have 10 children, I'll give you 1 vial or 2 vials. So what happens to that? They get less than adequate. They're less than adequate because the person issuing the vaccine doesn't appreciate that the policy says that you must vaccinate every day, and that in itself means that wastage rate for some vaccines goes high. The other thing is that the data that is used for vaccine forecasting at various levels may not be the true data, may be estimates that do not reflect reality, and therefore they get less than adequate vaccine. And that thing that contributes to less than enough stock is when we have stockouts. We have had stockouts, several stockouts in the last 1 year or so. There is rationing. So when rationing is there, when enough vaccine is there, whenever you get enough vaccine, communication doesn't go out on time to say now that we got enough stock, you can continue using vaccine the way you're using. Sometimes that is delayed. So those are some of the things that we can think about.
Thank you, Isaac and Wendy, for that. We have a question around micro planning and how in that in their program they've been pushing micro planning to a facility level, and it shows that our findings that are indicating that this is causing health workers more work, but not necessarily helping them to do their jobs. The question is, if they had better data to begin with, would that, in our opinion, motivate them to plan and track as recommended?
This is Wendy. That is a great question. And I think at the facility level, the micro planning is actually very accurate. And what we saw during the research is that health workers absolutely know their community and know the number of children that they need to reach. And they understand that from that micro planning process. I think the issue is when that micro planning gets taken up the chain of command and gets into the overall system, that there's a disconnect between the more accurate micro planning at the facility level and how that gets recognized at the national level for overall planning. And I think I think the data through micro planning is actually pretty accurate because they know their communities very well. But it's when it gets aggregated up is when it gets muddled, and how to accurately support that micro planning financially from higher up levels. That's where the breakdown gets through. And it also speaks to the system itself, that Ministry of Health and EPI sits on one place, but financial decisions are sitting somewhere else. And how do you, and once immunization planning and budgeting gets aggregated into overall Ministry of Health budget, how do you make the case for immunization? It's that like squeaky wheel gets the oil whole adage that like making noise for immunization and advocating for immunization to get more funding and accurate funding flowing down to where you actually can spend them, where the money needs to be to spend.
Yeah, Wendy, and if I could just add on to that, I think that was one of the insights from this work is, you know, I think everyone now has heard better data, better planning, more efficient planning processes. But I think what we've really seen is that there's also the flip side of there also needs to be reliable resources and funding that's coming at the other end of the planning process. So, you know, obviously data quality is an issue, but also the fact that as I'm planning, I already know I'm not going to get what I'm planning for is also a demotivator and is equally as big of a challenge.
Thanks for that, Emilia and Wendy. We have a question here regarding the workarounds that you mentioned earlier, Wendy, and whether there's recognition by supervisors or even higher level staff that some level of innovation or adjusting to the practice, as we've been saying, is needed or should be encouraged. How have they been receiving that, supervisors and higher level staff?
The quick answer is I don't think they are recognized. And I think that's one of the drawbacks of having these innovative ideas, that they are not recognized by supervisors because they are not part of this official policy system. And I think the call to action is how do you create a culture that recognizes and really encourages innovation, because there are some good workarounds that work for healthcare workers that help their daily work, but how do you get that recognized by supervisors so then it's not a punishment, that's too strong of a word, but a more supportive way and approach to recognize and encourage health workers to figure out what works for them and figure out how to make sure kids get immunized, which is exactly what we want at the end of the day.
Yeah, I think we don't have a system that is able to pick workarounds from the subnational level, to be able to synthesize them and refine them so that they can be adapted to the system. That is what we lack, because we are stuck with following the policy and implementing the policy, even when the policy is not doing what it's supposed to.
Thanks for that, Isaac. We've reached time at the moment, but there is still a few questions that need to be answered, and we're going to follow up on those on the TechNet forum, which you can head to after the webinar. But we also encourage you to download our Kenya Insights report, which you can also find links to through there, and continue to read our blog series, which we're posting on Medium at the moment. We're going to be running our next webinar on the 30th of July, and that will be talking about WhatsApp and how it's transforming communications in the Kenyan health system and how we saw it used extensively as an informal channel to send data up and down throughout the system.
Okay, thanks a lot. Wendy, anything else you would like to add before we wrap up?
No, I think that's it. Thank you very much for all the participation and the questions. We'll respond, as Sarah said, we'll respond on the discussion page on TechNet and continue the conversation.
Right, thank you very much. So thank you for your participation. We're going to follow up on the TechNet website. You'll see that on the forum, and the presentation will be posted today on the website, and the video will be posted either tomorrow or Monday, the latest. Thank you again, and have a great day or evening, everybody. Bye, everybody.
Thanks, everyone.
Bye. Bye. Thank you.